Welcome back. I'm Dr. Ali Sabbour, Professor of Vascular Surgery, Ain Shams Medical School, and this is part 2 of the recorded lecture about surgical site infection. In this part, we will discuss how to prevent and how to manage surgical site infection. This is a reminder of the ILOs of the 2 lectures. You can pause the video if you wish. Guidelines for antibiotic surgical prophylaxis has been sent to you and will be discussed with examples for application in your second face-to-face session. However, what concerns us here is the classification of wounds according to its contamination. It is important to classify surgical wounds according to expected contamination because this is the base for antibiotic surgical prophylaxis. According to contamination, surgical wounds can be classified into 4 categories. Clean. The surgical incision is in a healthy skin for an elective operation, not traumatic, not post-traumatic, with no viscous opened. This includes no injury of the alimentary mucosa, respiratory mucosa, genitourinary mucosa, or traversing the oropharyngeal cavity. Classical examples are hernia repair, cosmetic surgery, and mastectomy. Those patients do not need antibiotics. Please remember that clean operations that include insertion of prosthetic material should receive antibiotic prophylaxis. Clean contaminated wounds. Surgical wounds non-traumatic involving opening of a viscous with minimum spillage. This includes penetration of alimentary, genitourinary, and respiratory mucosa under controlled condition without unusual contamination. Classical examples are elective cholecystectomy, uncomplicated appendectomy, transurethral resection of the prostate, and laryngectomy. Prophylactic antibiotic is indicated in those patients. Contaminated. Surgical wounds with open viscous and significant spillage, what we call macroscopic soiling, or acute inflammatory disease, example emergency appendectomy. Classical examples are large bowel resection, biliary or genitourinary tract surgery with infected bile or infected urine. Clean traumatic wounds infected in a contaminated field, the street for example, are considered contaminated. Prophylactic antibiotic is strongly indicated. Sometimes consider therapeutic antibiotics, which includes prolongation of the antibiotic course. Dirty operations, traumatic wounds from a dirty source, or surgical wounds with pus released, example, incision through an abscess, or gut perforation with significant contamination, example, perforated colon with colonic content inside the peritoneal cavity. In these patients, the use of antibiotics is prolonged to a therapeutic course. Surgeries that require antibiotic prophylaxis are clean surgery involving the placement of prosthesis or implant, clean contaminated surgery, contaminated surgery. You may use antibiotic prophylaxis in clean operations in high-risk groups, for example, immunocompromised patients. Surgery on a dirty or infected wound requires antibiotic treatment in addition to prophylaxis. This is according to the NICE clinical guidelines recommendations. Antibiotic prophylaxis should not be used routinely for clean, non-prosthetic, uncomplicated surgery because of the risk of adverse effects. Clostridium difficile associated disease, resistance, and drug hypersensitivity. General rules about antibiotic surgical prophylaxis. Number 1. Choose the antibiotic based on the expected spectrum of organisms that will contaminate the wound. Consider the local hospital antibiogram and resistance. Number 2. Give a single shot in the decisive period, when local wound defenses are yet to be established, because we want a maximum blood and tissue level present at the time of skin incision. That is the time of organism inoculation. Give this single shot within 120 minutes before skin incision. Practically, we do this with induction of anesthesia. Antibiotics may be repeated at 8 hours, 16 hours in long operations, or with prosthesis, or with excessive blood loss. Please consider the half-life of the drug. You continue antibiotics as therapeutic antibiotics if there is unexpected heavy contamination. Please remember that patients with heart valve disease of prosthetic valves should be protected from bacteremia caused by dental work, urethral instrumentations, or visceral surgery. Do not abuse antibiotics. The emergence of bacterial strains with antibiotic resistance is a seriously growing problem. The emergence of what is called a superbug, which is a bacteria resistant to all known antibiotics, is a real threat. As surgeons, it is our responsibility to use antibiotics properly to be effective and in the same time prevent or hopefully delay the emergence of resistant strains. Please remember that antibiotics can never replace a sound, neat surgical technique with gentle tissue handling and good hemostasis. Now, how to avoid surgical site infection? You can now recognize that to avoid surgical site infection, there are measures that should be taken before the operation, within the OR, and in the post-operative period. Pre-operative measures include: plan for a short pre-operative hospital stay. This lowers the risk of acquiring multi-drug resistant hospital strains infection. Pre-operative shaving should be avoided. Hair should be removed only with a clipper, because minor skin abrasions enhances skin colonization. A bath or shower prior to surgery is recommended. Surgical antibiotic prophylaxis should be administered prior to the surgical incision, when indicated within 120 minutes before incision, while considering the half-life of the antibiotic. Operative theater measures include standardized scrubbing, gowning, masking, with paying attention to theater discipline. Standardized patient skin preparation. Use alcohol-based antiseptic solutions. Staff with hand infection should not enter the OR. Practice sound surgical techniques, gentle tissue handling, absolute hemostasis, avoid dead space. Consider having severe contamination, in this situation, those wounds are better be left opened for delayed primary or for secondary sutures. Ensure proper oxygenation all through the operation and in the early post-operative period that is done in the recovery room. Maintain normal blood gases and the body temperature. Avoid hypothermia perioperatively. Post-operative measures. There is a strong evidence that recovery room oxygen therapy reduces the incidence of surgical site infection. If macroscopic contamination occurs during the operation, extend antibiotic prophylaxis and use antibiotics for therapy in dirty wounds. Medical staff should wash their hands between patients if they want to reduce or eliminate the cross-infection from one patient to the other. The length of hospital stay should be kept to a minimum. The question now is how to suspect, then how to treat surgical site infection. Redness, swelling, pain and tenderness, purulent discharge from the wound, or wound dehiscence. All of them are indicators of surgical site wound infection. Other indications of infection include fever. It is worth saying that with a short post-operative hospital stay and early discharge of patients, the early diagnosis of surgical site infection can be missed by the surgical team. Cellulitis around the wound by invasive organisms takes from 2 to 3 days to develop. So this is why if you discharge the patient earlier than the second day, you may miss it. Suppurative wound infection takes from 7 to 10 days to develop. I'm going to give you clinical examples of surgical site infection, wound grading. All of this will be presented in the face-to-face session. Guidelines for treatment of surgical site infection will be presented in the face-to-face session as well. How to suspect and treat surgical site infection will be discussed in the face-to-face session. Principles of surgical site infection management, that includes indications for antibiotic therapy, will be discussed in the face-to-face session as well. Antibiotic choice. How would you choose the antibiotic? Whether to choose it empirically or based on culture and sensitivity. The role of pus culture and gram stain films. And the concept of downscaling. You can pause at any one of the previous slides to read the content, or you can wait to discuss these in the face-to-face session. Please remember that antibiotics are not an alternative to pus drainage. If pus is formed, it should be drained. Please be ready with your questions in the next face-to-face session. This is the end of your recorded session. Your face-to-face session will start with simple questions related to the content of this presentation. I'm expecting all of you to be ready. Thank you.